welcome everyone in our audience on this warm and thunderous February evening to the latest offering of our Hot Topics in Public Health series. Tonight's program is on understanding the impacts of Wisconsin's birth tax, a reproductive justice approach. I'm Dr. John Tempte. I have the pleasure of serving as Associate Dean for Public Health and Community Engagement at the School of Medicine and Public Health. Next slide. Before we start, I'd like to acknowledge that the University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Dejope since time immemorial. In an 1832 treaty, the Ho-Chunk were forced to cede this territory. Decades of ethnic cleansing followed, when both the federal and state government repeatedly but unsuccessfully sought to forcibly remove the Ho-Chunk from Wisconsin. This history of colonization informs our shared future collaboration and innovation. Today, UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nation of Wisconsin. Next slide. Well, this paper emerged this past October regarding the public health crisis of maternal mortality within the United States. Next slide. The first line of this paper reads as follows. The United States has the highest rates of maternal mortality and morbidity among high-income nations, with specific populations at increased risk, including pregnant people of American Indian or Alaska Native and Black backgrounds, those of lower socioeconomic status, and people younger than 18 years and older than 35 years. Next slide. To help us understand some of the underlying causes of this disparity, I have the great pleasure to introduce tonight's speaker. Dr. Tiffany Green is a nationally recognized economist, population health scientist, and science communicator, whose mission is to reduce and eliminate racial and ethnic disparities in reproductive health. Dr. Green is professor of population health sciences and of obstetrics and gynecology at the University of Wisconsin-Madison. Her PhD is in economics from the University of North Carolina at Chapel Hill. She is motivated by the persistent unsolved puzzle, how and why Black people with a capacity for pregnancy experience the worst reproductive health access and outcomes of any racial or ethnic group, and what innovative solutions might ameliorate these persistent inequities. Dr. Green is a member of the Wisconsin State Maternal Mortality Review Team and proudly served as the inaugural co-chair of the Black Maternal and Child Health Alliance of Dane County. Next slide, please. Serving as our moderator tonight is my long-term clinical partner and associate professor in the Department of Family Medicine and Community Health, Dr. Jessica Dalby. Dr. Dalby has been at Winger Family Medical Center since 2012. And I'll add, she was one of our wonderful residents before that. Her bachelor's in biochemistry is from the University of Texas at Austin and attended medical school at Baylor University or Baylor College of Medicine in Houston. She has a wide-ranging interest in family medicine and practices full spectrum care, including obstetrics and working with neurodiverse individuals. She has pursued a lot of additional training in reproductive health. She teaches her residents in this area and currently serves as the medical director or medical consultant for sexually transmitted infections for the City of Milwaukee Health Department. Next slide, please. A couple of quick notes before we begin. To facilitate our Q&A, please send any questions to communications@med.wisc.edu. And we have the great pleasure to be working with an American Sign Language interpreter and live captioning through the McBurney Center. So our gratitude to you for doing this. Next slide. We have no conflicts of interest to disclose. And next slide, the accreditation information is provided here for continuing education credit. Next slide. Finally, our learning objectives for this evening are as follows. Define the reproductive justice framework. Explain the scope of reproductive health inequities in the state of Wisconsin. And 3, analyze the birth cost recovery policies in the state of Wisconsin. And without further ado, I have the great pleasure of turning this program over to Dr. Tiffany Green. Thank you.
Okay, thank you so much for that great introduction. I am really gratified to see so much interest in this topic. Birth cost recovery, also known as the birth tax, also known as birth expenses, is something that is such an important part of the lives of so many low-income Wisconsinites, and as well as the folks in those few states that still practice this. But I think there's so much work that we need to do to really truly understand the impacts on the health and well-being of this population. And this has unexpectedly become such an integral part of my own research and my scholarly work, and to the people in my life who are probably tired of hearing me talk about it, just regular conversation. And I'm grateful to be in a position tonight to partner with other scholars and folks in communities. Some special thanks. And before I do that, I want to kind of give you an overview of where we're going. First, I'll give you some background on reproductive health inequities in Wisconsin and how they compare to what we see nationally. We'll then review birth cost recovery policies, and I'll tell you what we know and what we don't know about their impacts on families. And importantly, why I think this is a reproductive justice issue. After that, I'll talk about our evaluation of birth cost recovery on child support related outcomes and let you hear Black birthing people's perspectives on this policy and the challenges and amazing opportunities that have come out of this work. At the end of this presentation, the hope is that you will be convinced that it's important to build a rigorous evidence base on birth cost recovery so that we can advance policies that support the needs of our people. I want to thank quite a few partners: the Wisconsin Partnership Program, the Wisconsin Department of Children and Families, the UW School of Medicine and Public Health Centennial Scholars Program, and Dean Golden for their generous support. And without them, I would not have been able to do this work, as well as the County Health Rankings and Roadmaps Initiative. As always, these opinions are my own and should not be taken as any of their positions. More thanks, of course, to the Wisconsin Administrative Data Corps that's housed in our Institute for Research on Poverty, who provided critical data. My home department of Population Health Sciences, who is having a pizza party without me. I hope they're enjoying that, but thank you. And my second home department of Obstetrics and Gynecology for supporting recruitment, as did the Department of Family Medicine here at UW. It takes a village to do this work, and I want to acknowledge some of the folks that have been in this space with me and have partnered with me at various stages of this process. They include Hua Vu, my former postdoc exceptional scholar, now lead economist at Northwestern, along with Steve Cook, who is not pictured here and is now enjoying his well-deserved retirement from IRP. We conducted the first analysis of the impact of the birth cost recovery cessation on child support outcomes that I'll talk a little bit about today. Dr. Laura Swan, my research scientist, brilliantly leads our qualitative arm of this work. Clara Lerma, who is not pictured here, recently joined my group as a research director and has worked to get our recruitment in order and the rest of our house in order. I'm very grateful for that. I've also benefited from the wisdom and the knowledge from soon-to-be Dr. Gina Green-Harris, Dr. David Pate, and Dr. Jasmine Zapata. Not pictured here are our interviewers, Michaela Miller and Obi Anaya, who have been doing some of the qualitative work that I'll talk a bit about. As you will see later in this presentation, our community partnerships are also an integral part of this work. We're grateful for the work of Annette Miller, who is the CEO of Equity by Design, our expert community consultants, Felicia Turner-Walton and Tara Wilhelmi, and of course, our amazing community advisory board co-led by Dr. Beth McManus and Ms. Carla Gaines, and our community advisory board, Jacqueline Sills-Wares, Brandeis Hatcher, Sharon Rice, and Deborah Nevels. And our team is growing, so please stay tuned, all right? So first, I think it's useful to give some background on why birth cost recovery is something worth knowing about. But first, I think a little context is very helpful. So this chart is a very good encapsulation of one of the main reasons why I felt it was important to return to Wisconsin back in 2019. Black babies experience poor health at birth on almost every metric, including higher rates of low birth weight, that is weighing less than 2,500 grams at birth, and are more likely to be born too soon, less than 37 weeks, compared to all other racial ethnic groups. And these things, especially preterm birth, are really strongly linked to infant mortality or an infant dying before the end of their first year of life. Wisconsin's Black infant mortality rates are particularly noteworthy. After a period of improvement in the 2000s, Black infant mortality in Wisconsin is very consistently among the highest in the United States. I should note that it fluctuates from year to year. The latest data that you see here from the Vital Statistics, which is the universe of all births, shows that for every 1,000 live births to Black birthing people, 14 of those babies don't make it to their first birthdays, and that's second only to Kansas. Severe pregnancy-related morbidity is also a health indicator that I think it's worth talking about. Severe pregnancy-related morbidity refers to a pregnancy complication like having an embolism, having a cardiac arrest, or some severe condition that could lead to the death of the pregnant person. And just so we're all on the same page early, I use the term pregnant or birthing person as recognition that not just cisgender women can give birth, and this population includes trans men, non-binary folks, and other gender diverse populations. Back to the subject, what we see here is that from the data is that although pregnancy-related morbidity, severe morbidity is lower, overall in Wisconsin, racial inequities are wider. This is particularly true for Native American and Asian populations. For example, Native American white inequities in severe pregnancy-related morbidity are about 147% higher nationally, but 184% higher in Wisconsin. And again, you can see that Black and Native American pregnant and birthing persons experience the highest rates of severe pregnancy-related morbidity. Before and after giving birth, we also see that people of color generally have higher rates of postpartum depressive symptoms. And so how we know this is that on a screener question, somebody might ask, I've been worried or anxious for no reason. Yes, very often, right? In whatever case, we know that these rates are particularly high among Native American and Black postpartum populations, as you can see from this slide. And in Wisconsin, we know from pregnancy risk and management system data, which are population level data that tell us about the experiences of people that recently gave birth in Wisconsin, that Wisconsin Black birthing people experience elevated depressive symptoms relative to their white counterparts. So what are the causes of these inequities? Well, we know now that there's a widespread recognition that these inequities are not due to individual behavior or cultural dysfunction or deficits. and that it is necessary for us to address the structural determinants of pregnancy-related inequities. That is, where we live, where we work, where we get health care, and where we play fundamentally shape our access to opportunities and ultimately health. More notably, we know that structural racism, or the macro level systems, social forces, institutions, ideologies, and processes that generate and reinforce racial inequities, shape inequities in all things, including pregnancy-related health outcomes. For example, we know that segregation, or the spatial separation of racial groups, and particularly that separation that is linked to resource hoarding, is associated with stillbirth, low birth weight, and preterm birth among Black people. We've also found this in our own work and find that some of the mechanisms are through decreased public spending in segregated areas and increased food insecurity. We also know from work from economists that Black-white gaps in preterm birth are larger in more racially prejudiced areas, and particularly when it comes to anti-Black prejudice. Finally, from our own research group's work, led by sociology doctoral student Emma Ramel, we found that areas with higher rejections of Black loan applicants conditional on income is linked to lower birth weight among Black babies. So as you can see, I'm very interested in how structural factors, including policies, affect reproductive health outcomes. But how did I get interested in birth cost recovery? Well, that is a tale that I will tell you now. It was fall 2019. I had just returned to live in Madison to start my new faculty job as part of the cluster hire in reproductive equity. And I was trying to wind things down at my former institution. I had a 3-month-old and a preschooler, and trying to sell my house while sell my old house while moving into a new one. And to be quite frank, I felt like I was drinking through a fire hose, right? And during that time, I had the opportunity to attend the Foundation for Black Women's Wellness annual Black Women's Wellness Day. It was an amazing opportunity to meet all kinds of people and understand the important work that was being done here in Dane County and outside of Dane County to promote Black women's health. My friend, Dr. Michelle Robinson, who is now the director of the Office of Health Equity at the Department of Health Services, introduced me to the woman that you see in this picture, Rachel Azenleko Akuete. Rachel was just so kind to me and agreed to meet me for coffee. And during that coffee, she tells me about this policy called birth cost recovery. And until that point, I had never heard of this. And I was frankly quite shocked that there was a policy in Wisconsin that required unwed fathers to pay back a portion of Medicaid labor and delivery costs. But then my economist ears perked up. She told me that Dane County had decided to stop collecting new birth cost recovery funds starting in January 2020, but that Milwaukee had considered it, but would not be stopping this program at the time. And I said, okay, who's evaluating this program? And she said, well, no one. And then I said, I guess it's going to be me. These were famous last words, by the way, because then came March 2020, and we all know what happened then. But in all seriousness, birth cost recovery is a policy that allows states to recoup Medicaid birthing costs from non-custodial fathers. There are several states that practice this. They include Kansas, Michigan, Pennsylvania, Minnesota, and Wisconsin. All these states have interpreted federal Medicaid law in such a way that allows them to impose liability on unmarried fathers. Although policy implementation varies across states and even across our counties, it works a little bit like this. A person discovers they're pregnant. They can decide to enroll in prenatal care, and Medicaid. In our state, Medicaid is known as BadgerCare. A person gives birth on BadgerCare. Again, the state cannot withhold birthing coverage if the father is not declared, but if a person has any kind of state benefits, including Medicaid or BadgerCare, the state can go after the father for some kind of support. I think what's important to remember here is that birth cost recovery is not child support, but it does require that a child support case be opened. And if that person is charged, or if the courts determine that that person owes child support, they may or may not be charged with birth cost recovery or birth expenses as well. But the important thing to remember is that birth cost recovery or birth taxes are not child support, but they are part of the process. And if the father is determined to be liable for that, their wages may be garnished, or a payment plan will be established. It's important to remember that some states, including Wisconsin, will disenroll otherwise eligible postpartum people if they fail to identify the father. Mothers and other birthing parents can request good cause exemptions for situations like domestic violence. I should also note that there's a 2018 rule change that instructed child support agencies to avoid pursuing birth cost recovery in cases where parents were cohabiting. That is also known as the intact families rule. So back to this question of structural racism. As you can see from this chart, unmarried people on Medicaid represent the majority of births among Native American and Black Wisconsinites. In turn, this is a population that is potentially vulnerable to experiencing birth cost recovery. Why is this? Black people, for example, are disproportionately covered by public insurance due to systemic racism that's led to higher poverty rates and decreased access to employer-sponsored insurance. And in Wisconsin, we have consistently documented large Black-white inequities related to incarceration, unemployment, education, and poverty. So unfortunately, none of this should be particularly surprising to us. Why is birth cost recovery an issue of reproductive justice? I think I will let one of the godmothers of the reproductive justice movement, Professor Loretta Ross, speak on this issue far more capably than I ever could.
When it comes to reproductive justice, start with the pregnancy, starting at the wrong place. You have to start with what's going on in the person's life before they're pregnant. My name is Loretta Ross, and I'm a reproductive justice and human rights activist. I was one of 12 Black women who helped create the term reproductive justice when we spliced together reproductive rights and social justice, because there were social justice issues prevalent in a pregnant person's life long before they even knew they were pregnant. Because if they had housing insecurity or fear of losing their jobs or fear of violence in their lives, that would determine whether they would keep an unplanned pregnancy or not. Now, in short, reproductive justice has three basic principles. Every human being has the right to not have a child and use birth control or abortion or abstinence if that works for them. And we have to fight for the right to have the children that we want to have. And that's the second tenet. And it spawned a whole movement called birth justice, which is to control the conditions under which we have children. And then the third tenet is once the baby is born, we fight for the right to raise our children in safe and healthy environment. Now, 10 years after 1994, the LGBT movement added a fourth principle about bodily autonomy, gender identity, and sexual pleasure. I'm not surprised that reproductive justice emerged out of Black women's reproductive experiences, because when we were kidnapped from Africa and brought here to breed as a wealth building strategy for capitalism, then our children were prized. But that same womb product became problematized and criminalized after slavery. I'm really invested in people seeing their entire world through the human rights framework. It doesn't matter what economic or social system you live under, because if it protects your human rights, that's the system you need to work to build. If it violates your human rights, that's the system you work to deconstruct.
So what is the birth of the reproductive justice movement? In preparing for this lecture, I had the privilege of revisiting the origins of the reproductive justice movement as described by Tony Leonard. So in 1993, the Clinton administration was advocating for healthcare reform. But these healthcare reforms that the administration had proposed, many in the women's health movement felt they weren't enough and that they needed to cover all reproductive health services, including abortion. However, and so in that context, the Campaigns for Women's Health develops a women's health agenda. However, there were 12 Black women that were gathered at this conference, sponsored by the Miss Foundation and the Pro-Choice Alliance of Illinois. And they felt, the founding mothers of this movement, they rightfully believed that this advocacy didn't capture the needs of the most vulnerable. They didn't capture the needs of economically disadvantaged people, including the needs for abortion coverage, for well women care, and postnatal care. It didn't address the fact that women of color disproportionately face conditions like fibroids and breast cancer and infant and maternal mortality and HIV/AIDS. And so in this context, Women of African Descent for Reproductive Justice was formed. And so the founders of the movement, Toni Leonard, Alma Crawford, Evelyn Field, Terry James, Basola Marignay, Cassandra O'Connell, Cynthia Newbill, Elizabeth Terry, Loretta Ross, and Abel Mabel Thomas, Wynette Willis, and Kim Youngblood formed what is now known as the reproductive justice movement. Over subsequent months, these women worked to organize, and at a certain point, 836 Black women, including Congresswoman Maxine Waters, she was not a congresswoman at the time, Eleanor Holmes Norton, and more, signed a letter with demands to Congress. What did they demand? They demanded healthcare reform that included full spectrum reproductive healthcare. They demanded universal coverage and access to care. They also demanded that this care be comprehensive and that people be protected from discrimination. And in that, from this organizing, Sister Song, which is the renowned coalition of 16 women of color-led organizations in the reproductive rights, health, and justice spaces, was born. And so what are the tenets of reproductive justice? They're very simple and they're very powerful. They involve the right not to have children. They involve the right to have children under the conditions that we choose, the right to parent children in safe environments. And the founders were very clear. These tenets apply to anyone who can bear and parent children, which of course encompasses, but is not limited to trans, intersex, and non-binary humans. Importantly, reproductive justice is a framework and a movement that analyzes and interrogates and criticizes systems of power and oppression, and it centers the marginalized, and it draws from a human rights framework. It is not limited in any way to Black people, but it is grounded in the experiences and the leadership of Black women. So why is reproductive justice, and why does it have to do with birth cost recovery? Well, birth cost recovery is a policy that people argue impacts their ability to parent their children in safe conditions. There's been a lot of debate over this policy, but there honestly is not a lot of evidence on the impacts of these policies on the outcomes of low-income parents. So on one hand, supporters assert that birth cost recovery promotes parental responsibility and is needed to sustain safety net programs and child support services. On the other hand, people who detract from this program suggest that birth cost recovery impedes parental involvement. It leads to financial strain. We do have, in one of the few rigorous papers on this outcome, we can see that it affects fathers' unemployment. And importantly, these differences are racialized. Black Wisconsin fathers have more limited social networks for employee referrals and earn less income. Birth cost recovery might potentially strain couples' relationships and reduce paternal involvement, again, which has adverse impacts on child health. There's anecdotal evidence that suggests that pregnant people may avoid prenatal care in order to circumvent relationship conflict. And this could in turn result in poor pregnancy-related outcomes. But the reality is it's been very difficult to rigorously examine these claims for a couple of reasons. And the main one is that it's hard to see if we're looking at correlation or causation. That is, birth cost recovery primarily affects low-income people, and there are conditions that are associated with poverty that I can observe as a researcher, and that I can observe that are also correlated with poor outcomes. It might be that there's some underlying stress that affects your propensity to get involved in birth cost recovery, but also affects your health outcomes, right? But then came this policy change. So in 2016, Dane and Milwaukee Counties collected more birth cost recovery funds than any Wisconsin county. Both counties actively debated eliminating birth cost recovery as a result of community advocacy and input from other stakeholders. And that includes ABC for Health, a public advocacy law firm, folks in communities, and even more. And because of this, Dane County ceased birth cost recovery in January 2020, while Milwaukee County debated eliminating birth cost recovery, but ultimately at the time decided to retain this policy. So using this policy change, we can theoretically get a little closer to understanding the causal impacts of birth cost recovery on outcomes. So our original plan was to assess the impacts of this policy on birth outcomes. However, we quickly realized that the data that we proposed to use, Medicaid data, was not appropriate for this purpose, which I'm happy to talk about a little bit more in Q&A. But back on topic, we decided to focus on other outcomes related to child support. And the question we asked was, did this policy change in Dane County help with increasing child support compliance among fathers? So how do we do this? This is work, as I said before, from Dr. Hua Vu and Steve Cook, where we draw from Medicaid, child support, and unemployment insurance data. We wanted to understand whether the policy change in Dane County impacted whether fathers owed child support, how much they owed, and whether they were compliant with these orders. We did it by looking specifically at pre and post trends in Dane County versus other counties. And without getting too much into the weeds, because there might have been other trends going on that might have influenced child support outcomes, we tried to control for these factors like poverty rates, average rates of unemployment, and other differences between counties that might have affected outcomes. And we used a method of causal inference called difference in difference analyses. What did we discover? So I like a too long don't read, like most of you. So one, we discovered that there was, yes, absolutely an increase in child support owed, but more importantly, there was an increase in the child support that families or the birthing parent received. In other words, the birthing parent was more likely to actually receive support and more of it. So instead of the money going to the state, we saw more money going to the birthing parent among people that lived in Dane County post January 1st, 2020. We also noticed that Black parents disproportionately benefited. That is, the fathers of Black children had higher compliance and were more likely to pay more money in child support after this policy change. And we found that birth cost recovery likely narrowed racial inequities in child support outcomes, in part because things seem to get worse among the fathers of white children, and we're not fully sure why. There are, of course, a lot of limitations to this study. There was a little thing called the COVID-19 pandemic that made things challenging to draw strong conclusions. But I will feel, I think, more comfortable as we add data over time to try to confirm the robustness of our results. I should also note that while Dane County ceased birth cost recovery collections in 2020, they ceased new birth cost recovery collections and did continue collecting back receipts. So that may have muted the effects of the policy change in Dane County. But another problem that we have is that although Black people are likely disproportionately impacted by birth cost recovery. And their voices really are not heard very much in scholarly and in public conversations. And part of me was really concerned with making sure that the voices of communities that were disproportionately affected were heard. And I started to learn even more about this as I read the Saving Our Babies report that was put out by the Foundation for Black Women's Wellness. And as I dug through this report that talked to community members about what they perceived as the drivers of low birth weight in the community, what we found is that people identify birth cost recovery as a really systematic barrier to advancement. And specifically, they said birth cost recovery is a policy that magnifies financial instability for non-custodial fathers or penalizes mothers with healthcare coverage loss if they refuse to provide fathers' names. Such policies deepen many men's struggles to financially support their children and create strained family dynamics. And so I had the opportunity through the Wisconsin Partnership Program New Investigator Award to really try to center communities in this conversation and understand what their perceptions of birth cost recovery were and are. And the goal of this is to try to take policy evaluation at a different angle and to first document the experiences of people that are disproportionately affected by birth cost recovery, to create an innovative survey capturing outcomes that the community actually values, and work with the UW Survey Center, a renowned survey center, to validate the survey in this population to make sure that what we think we're asking people is what they think they're answering, and then to implement this survey among Black birthing people. And an important part of this conversation is making sure that we had community thought partners that would hold us accountable and make sure that we are meeting the needs of all of low-income Black and Wisconsinites. And so we worked with Equity by Design, which is a firm here in Wisconsin owned by Annette Miller, and help us ask a few questions. One, what do we not need to know that we don't know? Two, how can we do outreach and effective engagement of communities? And three, what are the lessons, the important lessons that we've learned about birth cost recovery so far? This is one important area where the Community Advisory Board was really helpful for us in thinking about whether we could ask questions in a way that were more useful. This is part of our screening tool that we used for some qualitative interviews. And you can see how or for question 2, we revised the question in response to our CAB's input, saying that we needed to scale down the reading level, that people in Madison and Milwaukee might interpret this policy differently, and more. So this is a really good example of how it's important to use community expertise to make your science more rigorous so that you're getting or you're eliciting the answers from your participants that you want to reflect these changes in policy. So how do participants think that birth cost recovery has actually affected their lives? Well, we have only a couple of interviews, but I think those interviews have really shed some important light on how people or birthing people, Black birthing people, are interpreting this policy. So we identify a couple of issues. One, fathers not having money for necessities or extras for their children. Two, that this policy could have negative impacts on bonding, that is father-child bonding. That these policy changes in Madison and Milwaukee at the time, and I'll explain later, could have inequitable effects across the two counties. And also that people that are on Medicaid or BadgerCare experience significant administrative burdens. That is, that navigating these systems make it difficult to access the benefits associated with Medicaid. Here's one example from one interview. Yeah, I mean, this person was talking specifically about how they thought fathers might be affected by being charged with birth expenses or the birth tax or birth cost recovery. Yeah, I mean, that could be challenging for the 5-year-old. I can't give you extra money for school clothing because I got to help pay the birth expenses, or I got to pay the birth expenses. Hey, I don't have, let's say if I was to run into a gym where I needed just $25 for gas, the funds are so tight that they not even leaving no room for the fathers to do anything extra or curriculum activities because they're getting this money taken out of their checks every 2 weeks or every week for child support. So as you can see here, this participant thinks that birth cost recovery is something that keeps dads from paying for both the necessities and child support. This participant also thought that this had a negative impact on father-child bonding, and specifically said if men didn't have this birthing fee right off top, that would make it a better relationship bonding for the mother, the father, the child. Men would be able to do more, provide more, and it'd be a healthy family overall. And participants also highlight potential inequities. So what is happening to Milwaukee when Madison has gotten rid of this policy? And specifically, they said, yeah, it just seems like it's more of a way to keep the urban fathers in some debt, on a debt to the state of Wisconsin, because if you're going to do it, I don't see why it wouldn't be the whole state. It's a state program. So you see these themes of feeling like fathers are not able to participate fully in their children's lives, and that the policy change in Dane County is going to introduce even more inequities among Black fathers. And then there are conversations about participating in Medicaid and BadgerCare. So my experience with them wasn't the best. I need more information. I need to know what's covered during my pregnancy, what's not covered, different things like that. What doctors are in the network, what doctor is not in the network. So I had to do a lot of the footwork on my own. It wasn't just like, hey, these are the doctors just in your network. These are doctors, it's not. These are services we provide. These are what we don't provide. So I didn't have none of that information up front. I had to do my own footwork. But like I said, I'm a mom of 7, so life is crazy and hectic for me. So it's just like if I didn't do the footwork, I don't believe they would have followed up and did the footwork for me. So what this indicates is that although this mother was able to navigate Medicaid, it wasn't in a way that they felt that they had the support of administrators or others to help them navigate the process. So what are the biggest challenges we face? Because I think it's important to be transparent about some of the challenges of research. We've gone to people, we've recruited for interviews to help understand birth cost recovery among low-income Black Wisconsinites. One of the challenges that we had is something that many qualitative researchers are facing, which is attempts at duplicate interviews, that people try to do multiple interviews so that they could take advantage of the incentive that we gave people for their time. Another challenge we have is that we had lower than expected recruitment numbers for birthing parents. We've had a lot of challenges getting people to sit down with us for interviews, which is completely understandable. People have busy lives. They have lots of challenges that we're facing. As someone who is busy, a busy mom with lots of children, it's completely understandable. And more important, there's no singular way of understanding birth cost recovery in communities. And I say Black communities because there is no singular Black community, even in Wisconsin. So what have we done to address some of these challenges? One is we've definitely implemented new screening protocols to make sure that we're only interviewing one person and that people can't take advantage of the incentive to do multiple interviews. And I want to emphasize that I'm not angry about multiple interviews. And I think it's really systemic of the fact that times are hard, and it's understandable that people would want to try to get multiple incentives. We are also partnering with obstetrics and gynecology, one of my home departments, and family medicine to recruit from clinics and also recruit dads. And that has been, I can talk a little bit more about that in the Q&A if people are interested, but that has been such a joyous process so far. And while I don't have anything to report yet that I'm really comfortable sharing, I hope to share more soon. And we're also working iteratively with our CAB and our other partners and talking to people in state government and other places to understand how we should be better presenting birth cost recovery and assessing it in our surveys, both qualitative and quantitative. And this is another example of how we have iterated. This was our first round of flyers, and we realized that people might be confused about birth cost recovery. And through the support of our outreach interns, Valeria Rojas and City Jenkins, the kids are amazing. I shouldn't say kids, but these young people are really just doing amazing work, and they helped us to revise our outreach materials so that we could better target the populations that we cared about. And we sort of shifted to talking about healthcare and child support programs rather than expecting people, especially birthing parents, to know what we were talking about birth cost recovery. And of course, the breaking news, there have been big policy changes even since we started this project. Most notably, Milwaukee County has stopped taking dads to court for Medicaid childbirth costs. So they are no longer implementing new birth expenses. There are still, like Dane County had before, back expenses, but they're working to mitigate those. And now birth cost recovery in Dane County is no more. Dane County will not be collecting back expenses either as of this year. So definitely huge policy changes, exciting ones that certainly complicate our research, but in a great way. What do we want to do next, given all of this? So I think we want to, I know we want to scale up recruiting Black fathers. I think our conversations so far initially have been really rich and important, and I think they have important things to add to this conversation. We want to continue to engage with county and state government stakeholders. Again, there are so many opinions and perspectives that we need to understand with this very complicated policy. And we hope to continue doing that so that we can serve as a resource for the decision makers in our state. I plan to continue centering Black Wisconsinites, particularly low-income Black Wisconsinites, but we like to expand to other communities. And it's not that I feel I have to lead that work, but as we can see from the graph before, this is a policy that also affects a large share of Native American Wisconsinites and Hispanic Wisconsinites. And I think it also probably affects other communities in very different ways that we need to better understand. And finally, I think understanding the effects of this policy, not just in the short term, but also long-term effects on families and children, is something that is worth pursuing. So where does this leave us? Back to the concept of reproductive justice. Reproductive justice is fundamentally about parenting the children that we have in safe and sustainable communities. And I think that studying birth cost recovery means that we do this work so that every baby born in Wisconsin can reach his, her, or their highest potential. I think that is the mission of my work. And as a mother, I also value that to the core of my being. Thank you very much.
Thank you so much, Dr. Green, for gifting us, more understanding of this topic. As somebody who has been providing OB care for a large Medicaid population for the past decade, it's also amazing to me that this isn't something that's been on my radar until recently, as I've heard you speak about this topic. So again, thank you for raising the awareness on that. A couple of questions. One, I was wondering, do you know, so currently Dane County and Milwaukee County are no longer pursuing birth cost recovery. What does this look like about other areas, in other areas of Wisconsin?
So as far as I know, other areas are still collecting birth cost recovery funds. There are some counties that do it a lot less, but as far as I know, all other counties are continuing to collect birth cost recovery. I think there's a good bit of latitude from the counties on how they can pursue birth cost recovery. For example, in Milwaukee, some time ago, they actually implemented a rule that said if the father's 150% of the federal poverty level or below, they're not going to charge them birth cost recovery. So I think counties have had a wide amount of latitude with which to choose or not choose to implement this policy.
Yeah, it's so yeah, it's so interesting to, again, as you hear this, and it just feels to me like, how could we be, how could we be doing this, holding, fathers of pregnant people and children who are on Medicaid to be accountable to pay back the cost of the birth. Do you have any understanding or context of, like, on a federal level, like, what was the original context of this, that, because it seems very disparate how it was picked up or not by different states.
Sure. And I want to emphasize that I am not a lawyer, and lawyers have a special language that, like economists, that I think they only speak. And so my understanding is that it is a unique interpretation of federal Medicaid law that allows some states to collect this. So all states, I guess, could technically do it if they wanted to, but only a few have chosen to continue to do it, and Wisconsin is one of them. And importantly, in Wisconsin, the counties are the ones that carry this out. And birth cost recovery is not a sort of separate thing, but it's bound up with child support. So if there's no child support case, then there's no birth cost recovery.
Just a few other questions that have come in. One question is that somebody had is what has or would make pursuit and impact of your scholarship easier in Wisconsin?
Oh my gosh, I love that question. Money. And I would say that not that of course everybody wants to be paid more money, but that's not it. I think that to do this work ethically and to do this work well, it requires us to make sure that we have funds to compensate expertise in communities, right? To make sure that people, that we're able to provide people with training, that we're able to compensate people for their time and their knowledge that we don't have, to make sure that we are able to hire RAs among students, among community members, so that we're not just extracting knowledge and extracting this information for our own personal benefit. But really, I know it sounds very naive, but I do believe in the Wisconsin idea that the work that we do needs to benefit the people of this state. And to do that, it requires resources. And I think even beyond money, support from those in government and bureaucracies to speak with us, which they have been doing, so that we better understand this policy and that we can translate it for the benefit of Wisconsinites.
Thank you. It sounds like another question came in just to help clarify, again, some confusion around the birth recovery tax, because it sounds like this has opened up a lot of people's eyes tonight who are listening. So a question is, even if the father is involved, is he taxed if he's not married to the mother?
That is a great question. So at this point in time, no. There was a time where that might have been true, but there was a policy passed during Scott Walker's gubernatorial administration that is more or less called the intact families rule. And so that is, if two parents are unmarried, but they are cohabiting and together, then they should not be charged. The father should not be charged for birth expenses. It is definitely an unmarried tax, because unmarried fathers are the ones who are in practice made to pay this expense. But again, it depends on the context. If the parents are together, they are not supposed to be paying this. If they're not together, then there is some chance that the father will have to pay. But again, it's contingent on there being a child support case opened by the child support office.
Wow. Another question came in. Do we have an understanding of the number of men who have been arrested or incarcerated due to birth cost recovery in Wisconsin?
That's a great question, and I don't know the answer to that. I think the important thing is really to think about whether people have, been arrested for non-compliance with child support. Again, I know this is not child support, but again, I think that would be, a more relevant question, and it's one that I don't know the answer to. I do have colleagues that, of course, that know a lot more about child support than I do, and I think it'd be interesting to answer that question for sure.
Someone has asked, how can people get involved in this issue?
I'm usually the researcher who sits at home and behind my computer and talks to people. In terms of getting involved, I think an important thing you can do is attend hearings when people are talking, when there are meetings at the county level, when, go attend, ask, visit your representatives and ask them about these policies, ask them to explain it to you, because as a constituent, you have a right to be informed about these kinds of policies.
Yeah, absolutely. And especially, because it's such a local level policy, enacted county by county, that it's a little bit sometimes easier to show up in a local county meeting than to, think about showing up at the Capitol, at the State House sometimes. Another question that I really appreciate, in our current settings, what are you most optimistic about regarding reproductive justice in our state and or country?
Well, there is a lot to be pessimistic about, but what I'm optimistic about is that there's recently been bipartisan agreement to re-implement the child tax credit, which we know has significant impacts on reducing child poverty. And so part of reproductive justice is, again, being able to raise our children in safe and healthy conditions. And being poor is antithetical to that. It is not that being poor is a moral wrong or anything like that, but it's just difficult when you cannot provide your children with safe and healthy conditions. So I'm very actually excited that the child tax credit will be implemented, and there's been bipartisan agreement on that end. That is something I think is worth being optimistic about.
Yeah, absolutely. I think it would be interesting as that gets reenacted to follow some of the rates of postpartum depression in people of low income. I feel like I saw a study several years ago about how the ability to afford diapers, or to those who struggled to afford diapers, had greater rates of postpartum depression, not being able to provide basic needs for your child, or struggling to provide those basic needs as encased in a bag of diapers. One other question, it's birth cost recovery seems to create another possible tenet of reproductive justice, i.e. the right to identify or not identify a father. What do you think?
What do I think about that?
Yes.
Oh man, y'all are asking a hard question today. So a couple of things. Reproductive justice are inherent in this idea is of bodily autonomy. And so I think the role of the state in this process is something that is not something that's unique to the modern era. I have a friend, Autumn Reinhardt Simpson, who's finishing up her history degree, and we were actually talking about birth cost recovery. And she said, Black in early modern England, the midwives would push unwed mothers to tell who the father of their children was, or they were going to the other place, right? So this is not anything new. This is not anything new. And part of this was because if the father was not identified, then the county or whatever area had to assume responsibility for the child. So I think what I'm trying to say is that we've always had this tension and these issues around who takes care of babies among us. And I think, of course, part of this, there are again caveats within the law that if a person is, for example, undergoing domestic violence or in some other situation, then they can ask for good cause exemption and not have to deal with birth cost recovery. But again, that is not necessarily something that everybody knows about or takes advantage of or is able to implement. So I guess this question is really a philosophical one, and one that I don't know that I've thought is thought very as deeply about. But I will say that I think people have the right to health care, and that people have the right to bodily autonomy without having that conditional on identifying the other person involved in making a child.
Thank you for those thoughts.
That was a hard question. People are asking the deep questions today.
It was, but I loved your like segue to like medieval England or early century England. Another question somebody asked is if you could say more about your experience putting together a community advisory board.
Yes. So I am a person who claimed that she would never do community engaged research or community-based participatory research. And, I first learned about that when I was doing a postdoc here at UW, the Health Disparities Research Scholars Program, which I now help lead. There's some irony there. But part of the idea of a community advisory board is that you need to understand why you have a community advisory board. A community advisory board should not be someone to just check off and give you credibility in an area. You want people who are going to hold you accountable. You want people who have knowledge that you did not. You want people who can give you insights that you wouldn't normally have. So once you kind of thought about your criteria for a community advisory board, in our case, we relied on Annette Miller, the CEO of Equity by Design, to help us reach out and think about how to approach people. We approached our two co-chairs. One, I happen to know them through my own work in birth equity, and I was so humbled and so thrilled that they had enough faith and trust in me to act as co-chairs. And the co-chairs helped us to recruit the other individuals on our community advisory board. So that is the way that we did it, and I'm making this sound a lot easier than it actually was. We also compensate our community advisory board, not enough for all of their expertise, in my opinion, but that process also involves paperwork. I hate paperwork. That was the only negative aspect of me doing this today, more paperwork. I don't know, clinicians love paperwork. But those were basically the steps for having a community advisory board. I'm also involved in helping with the community advisory board for a large study that we're doing, and the process is similar. Building relationships with key stakeholders in whatever area you want to do, and then bringing them together around this issue and compensating them for their time and expertise.
So another question came in to go back to the question 2 questions ago. Do you know how often a good cause exemption is approved? So, what's the hurdle that people have to present to, prove that they're a victim of domestic violence, for example, or, I guess I was thinking about in the cases of, when people have to like prove that they've been raped, and it can only, they can only qualify for certain things if they, have gone to the police. Are there similar hurdles or levels of proof to get a good cause exemption?
That's an interesting question. And it's an interesting question because I've heard competing things, I'll put it that way, about a good cause exemption. On one hand, I've heard that a good cause exemption is challenging to get. Most people don't know about it. I have also heard from child support that option is regularly presented in interviews with birthing parents. So I'll just say there are competing opinions about how easy a good cause exemption is to get, and I haven't been able to confirm one way or another. Both sources seem credible to me, so stay tuned. I hope that was politic enough, but yes.
One more question that has trickled through. Somebody is wondering if Wisconsin birth certificate practices have come up in your research and how that might intersect with the birth tax. And the example that they gave is that unmarried parents have to pay additional money to have the non-birthing parent added to the birth certificate.
Oh, I think this has come up in our conversations, the idea that they have to have it notarized, and that costs extra funds. No, it hasn't. I would love to hear more about what this person is thinking, and follow up a little bit. Is it just the fact that they have to have it notarized and that extra expense, or is there something else?
Yeah. One other question is, I guess I'm wondering, I feel like from like a systems perspective, when you hear about birth cost recovery, it seems a little bit unfathomable, right? That we're, holding the people who have often, the least resources to be, again, paying for hospital expenses for the birth. What do you think drives the continued participation in this policy?
Well,
there must be some benefit. I mean, what's
yes. So counties are able to keep, I think it's like 15% of these funds, and that helps to fund child support operations. And I think beyond that, so some people who support birth loss recovery say, look, this is important for being able to fund child support operations, keeping Medicaid BadgerCare solvent. That is a claim. I'm not adjudicating that claim, but that is what supporters say. And others would also argue that this policy helps to promote paternal responsibility. That is what the claim is.
How important your work then to, again, that as you show that fathers are more able to provide child support at greater levels when they're not being held accountable for paying back the hospital cost of the birthing process. I think that about wraps up our questions. I don't see anything else coming up through the question line. Again, thank you so much for bringing this important issue to light and continuing to use your voice in a consistent and persistent way to highlight these disparities and get to the bottom of some of these policies that impact them.
Absolutely. Thank you so much for having me.
Well, I'll step in here and again express our great thanks to Dr. Green and Dr. Dalby for a wonderful presentation this evening. I thank our audience for your interest, your questions, and some special shout outs here as well. So Maria and Leslie have been interpreting tirelessly through this entire period. So thanks very much for them and McBurney. Kelly has been the person captioning this talk in real time. From the School of Medicine and Public Health signature events, Tracy Gatos, Kane Grzekwa, and Jenny Strugnell helped to make everything flow wonderfully. And then our interprofessional continuing educational partnership staff, Barb Anderson and Shazad Bailak, helped to get everything set up for CME or continuing education credit. But again, a big thanks to everyone for this. This is the very first offering of Hot Topics in Public Health where we've had a tornado warning go off in the middle of it. And keep in mind that this is early February, so that'll give you something to think about on top of the Wisconsin birth tax. So I wish everybody a safe and pleasant evening. And again, thanks to you all. Good night.